That's what we learned from the great Italians. And right now we have a great Italian on the line, the great Dr. Greg DiFelice. Greg, thanks for joining me today.
Hey, Robbie, how you doing today?
Good. Thanks for interrupting your trip with the family to ski in Colorado. How's the snow?
Oh, it's awesome. We're getting some great spring skiing out here in Steamboat Springs.
Wow. Well, I was at the HSS cocktail party talking about you last night to everybody I could talk to.
Well, thank you.
Your name came up about how excited I was to have you. And now I hear Dan Buss is on the radio a lot in Minneapolis. And, you know, this is slowly starting to catch on, and orthopedic surgeons are realizing this is a great way to teach on the radio. So I may be on to something here, but it's great to have people like you who really enrich a show like this because of what you are seeing as a breakthrough. We were taught, our hands were slapped when we were told you cannot fix the ACL with sutures, you have to use a graft, because the joint fluid does not allow the normal healing process to occur to the ACL. Where did this inspiration come from? Teacher, remind us, where did it come from where you said, you know what, I know they say you can't do this, but I'm going to do it?
Well, when I first started out in practice, I was seeing a lot of really horribly injured knees with multiple ligaments out. Mm-hmm. And rather than try and reconstruct all of them, some of them would be just kind of torn right off the bone. Mm-hmm. And using some techniques that we started off with in the shoulder for rotator cuff repairs, I started to apply them in the knee and essentially kind of do a rotator cuff repair in the knee for certain ligaments.
Interesting.
And I gained some success doing that in the multi-ligament crowd. I started asking myself why it wouldn't work in the standard ACL, just an isolated ACL. And eventually I had the perfect patient present to me, and I performed it on him, and it worked to a T.
Wow.
So that was the first one. He's about 6 years out now. And it took me a while to, find out what the right tear type was and who would benefit from it the best. But slowly we've gotten the numbers up, and it's very encouraging.
What's really great for me is, reading about the art world for this show and going into Claude Monet and the Impressionistic painters who changed the world and just gave you the color on the canvas and lets your brain make it look like a lily pond and make it look like a tree or a person. But they could not have done this unless there was the tool available at the time, which was that paints were now in a tube with a replaceable cap. To some extent, it's the same thing for you. You can't put stitches inside the knee joint without opening the knee joint unless you have these new sexy tools for the rotator cuff that allows you to pass sutures like Arthrex and FiberWire and the tools that come from the rotator cuff in the shoulder that now allow you to make a breakthrough in the knee, right? I mean, you need the tools first.
Oh, absolutely. And I think, when I talk about this topic, I really think that the older surgeons, the historic techniques, they were really onto the right idea when they tried to repair it. They just didn't have the tools at the time, so it was the right idea, wrong execution, and through no fault of their own. And I do have to give a shout-out to Arthrex, which is the worldwide leader in making the products and the gadgets that we use to allow sports medicine docs to do what we do. And they've helped me. And in fact, I recently, last year, I released the technique worldwide. And because of this, I've been getting reports in from around the world that other surgeons have been trying this procedure with good success. So that it seems like the concept is gaining some traction, which is really great.
The greatest thing is when you can change the world anonymously. The Bible says the greatest gift you can give is charity, but don't put your name on it. And I think that to some extent, you'll see, I went through this with the patents that I had, where I would learn about cases done South America, in Europe, or patients I'll never meet, surgeons I'll never meet, using tools that I designed. It's like the greatest feeling in the world. So to get those letters, I know exactly what you're going through, and it's a beautiful thing. Tell us what's happening with these patients. So you started doing this a while back. You've now going to be writing a paper about these patients. So bring us up to date on your research and how these folks are doing.
Well, I'm up to about 35 isolated ACL primary repairs, and then closer to 50 if we include the patients who had multiple ligaments out at the time that the ACL was repaired. But academically, we can't really share things unless we put it into paper form. I mean, it's important that we wait until we have some longer-term follow-up before we start making conclusions. So this week and last, I've been putting the final touches on a series of papers and videos that will be published later this year, extensively detailing the results of the first 11 consecutive patients that I tried this procedure on. All of them are over 2 years out, which is kind of a cut point where you can make some conclusions, with an average of over 3 years out. And 10 of 11, or 90%, are doing just great. We're also going to present this at the Arthroscopy Association meeting in your neck of the woods in L.A. in April.
Wow.
So that should be fun.
Oh, I can't wait to see you when you come here. That'll be great. All right.
And, yeah, so it's, you know, the good thing about this is that sharing the experience out there with the world is, and with all the other medical community, it's most likely that the technique will morph into something similar but better as surgeons from around the world weigh in with their ideas and experience. And then hopefully my small experience will start a new conversation about ACL, which will refine the approach to the surgery and make it a less invasive, more biologic one that benefits our patients.
Unbelievable. Well, you know what's certainly going to be right there behind you is the biologics, you know, and I could also foresee you coming up with a way that surrounds the ligament you just repaired with a tube that keeps the synovial fluid away so that you can actually go on to heal. So there will be many gifts that you'll get from other areas as those tools and technology increase that you can borrow for the project that you have.
Absolutely. And once you get the idea, then it's just a matter of tinkering with it in the lab and trying to figure out how you can actually get it done. And sometimes we'll do animal models, et cetera, or some biomechanic work on the bench to see if it's appropriate before trying it in humans. But all of it's exciting because I think that it provides another way of thinking about ligament reconstruction.
So break it down for me. The ACL attaches to the femur, the thigh bone. It attaches to the tibia, the shin bone, diagonally comes across the joint, inside the joint itself. When an ACL typically tears, where does it tear? Teach the weekend warriors. Does it tear off of the tibia attachment? Does it tear in the middle of the ligament? Does it tear off the femur? Tell us about how these tears typically occur.
Well, really, it all depends on the mechanism of how you fall, you know. Football players have a different mechanism from skiers, have a different mechanism from someone who pops their knee stepping off the curb. And it's how the energy is transmitted into that ligament. Mm-hmm. So a good number of them, especially in contact sports, tend to tear the ligament right in the middle. And those are hard to repair because it's almost like stitching a horse's tail back together. Mm-hmm. The ones that I find are easiest to repair and have the best results are the ones that kind of peel right off the femur, off the thigh bone. Mm-hmm. And in fact, way back when, Mark Sherman did the paper on ACL repair back in the 80s and showed that, in fact, those patients, the ones that pulled off the thigh bone, had the best results. Even though the overall group didn't have very good results, that specific subset of patients did. And that's what I based my work on, is his conclusion or his observation that those are the people that did well. And it tends to cluster in skiers and people who have these kind of slow twisting injuries. Mm-hmm. Not exclusively, but certainly skiers tend to have more of those types of tears that are amenable to repair.
Teach us again, Greg, why so many more ACL tears in women than men? Almost 4 to 5 times more in women than men. Why is that?
Boy, you and I both know that's a hard one to answer. There's been quite a bit of effort and money and research time dedicated to trying to solve that problem. And they really haven't come up with an answer as to one specific reason why. It may be the bony structure where the angle at the knee is a little steeper due to women's hips being a little wider. But we don't really have an answer, but it certainly is true that the women suffer far more ACL injuries than men.
So, Greg, you finished at the hospital for special surgery what year?
1999.
1999. So who would you say was the most inspiring teacher for you? Who inspired you to look at things differently, to try to find a better mousetrap? Who was it there that inspired you?
Without question, Dr. Russ Warren, who was surgeon-in-chief at the time and team doctor for the Giants. He was what I consider my surgical father. You know, they talk about surgeons being in, you know, when you first start off, you're kind of cutting your teeth and getting things down, and then you're in the sweet spot of your practice when you're 15 years to 30 years out, and you've learned everything from all the surgeries you've done, and you're willing to try some new things. And then as you get further along, you're a little less willing to try new things because you've found out the ones that work. I think Dr. Warren is very unique in the fact that even well into the later stages of his practice, he's still perfectly willing to investigate new techniques and procedures, and he really just has an incredibly inquisitive mind as to trying to make surgery better and gain better outcomes for the patients.
You know, I had the great Hall of Famer, future Hall of Famer, Tony Gonzalez on the show as a guest, and I asked him, after 17 seasons of being in the NFL, whose voice do you hear in your head, I said, when you're on the field for the Kansas City Chiefs and the Atlanta Falcons? You know, which coach? He says, Dr. Klapper, I don't hear my NFL coaches in my head. I don't hear my college coach in my head. You know whose voice I hear in my head every time I run down that field to catch a ball? I hear my high school coach. And it's true. All these years, 26 years I'm in practice, I hear every time I do knee surgery, hip surgery, shoulder surgery, I still hear Dr. Ranawat, the first guy who taught me to tell us all, the eyes don't see what the mind doesn't know. You hear that voice from the first person who taught you about stuff. So it's interesting to continue to pay homage to the guys who actually, and women, who really taught us to be surgeons way back when. And it's really, he's very proud of you, I'm sure, because you've now carried the torch and the legacy continues. So keep thinking big thoughts, making the mousetrap better. And I want to thank you so much, Greg, for joining us today.
Hey, nice talking to you.
Okay, talk soon, Greg.
Take care, Robbie.
Enjoy the rest of your vacation with your family.
Bye-bye.
All right, bye-bye. Warriors, it's just, doesn't it give you a warm, fuzzy feeling? That's a guy you're talking to who's looking at the world differently. Can you imagine a world where you don't need a graft anymore to rebuild an ACL? Who would even think of such a thing? But it takes minds like that to see the mousetrap, and it could constantly be improved. All right, coming up next, we'll take your calls. We're going to